Hello everyone, my name is Rebecca Rowe and thank you for joining me this presentation on the APRN scope of practice, independent versus collaborative practice. Since the first nurse practitioner program was established at the University of Colorado in 1965 by Dr. Loretta Ford and Dr. Henry Silver, the growth from public health, pediatrics, women's health, and more recently adult acute care practice options provided nurses with the opportunity to not only add value to the health and well-being of our communities, it has also provided the evidence of quality that nursing brings to the table. That value-added provision has been proven since the times of Florence Nightingale, and for good or bad, every opportunity for nurses to advance has brought scrutiny and barriers to the ability to practice at the fullest extent of their training, education, and certification. So I wanted to take a little time here to delineate some of the differences between APRN designations and some of the specialties relevant to the practice authority, and provide a little bit of background on how the APRN specialties may define how practice authority works. There's a variety of options for the individual APRN. Due to states having their own regulatory boards, there are variances in how much authority each APRN designation is granted. In general, you may see some or all of these duties performed depending on which state you practice. Of the APRN specialties, the nurse practitioner role offers a broader practice range, while the APRN is more specialty focused. APRN's general duties and responsibilities include assessing patients, ordering medical tests, and diagnosing conditions. In addition to those general APRN duties and responsibilities, nurse practitioners do all these things, plus they can act as a primary care provider and may be considered a member of a medical team. Nurse practitioner must have at least a master's degree, board certification in a particular patient population, with the majority of nurse practitioners here recently landing in the family health realm. CRNAs select, order, and administer anesthetic medications, conduct pre-anesthesia patient assessments, and obtain signed consent, manage patients' airways, monitor vital signs during surgical procedures, and provide post-operative consultation. They must have a master's degree in certification, and in 2025, all new CRNAs will have to be DNPs. Those that already are established as CRNAs will be grandfathered into the practice. Certified nurse midwives can work in a variety of settings. They can supervise pregnancies, births, mother and infant pre- and postpartum care, treat male and female sexually transmitted diseases, and provide family planning guidance. So you can see that there are some differences in our practice arenas. Certified nurse midwives must also have a master's degree in midwifery training. Clinical nurse specialists, on the other hand, provide patient care in a specialty area, and they're usually disease-focused. They may focus on teaching nurses and staff. They may lead evidence-based practice projects, educating patients and their families and community members. They may provide expert consultation, precepting nursing students, conducting or assisting with research as well. The minimum for a CNS education is the master's degree. And certification is not always required, but is recommended. The opportunities for the APRN abound for the next decade, and the recent job growth projections between 2020 and 2030 are just kind of crazy. They're projected to be over 17,500 to 48,000 shortages of primary care providers. And that's just by 2034. That's not far away. To possibly divert this shortage, it may take some workflow intervention to determine how to remove some of the administrative and bureaucratic burdens to increase the amount of clinical work that have been prohibited because of all those other duties, and kept MDs, PAs, and APRNs from practicing to the fullest extent of their capacity. So from 2017, nurse practitioners have been the fastest growing workforce in the United States. They're trained and ready to take on the role of primary care provider based on their education. But despite that additional supply, there are still more patients than both primary care providers and nurses combined on a daily basis. Some researchers found that the amount of time it would take for a single physician to complete all of the recommended care management tasks to be performed would take a whopping 21 hours in a day. And that's unsustainable. The closure also of multiple rural hospitals since 2020 has resulted in the loss of access to basic health care facilities, and a few fledgling rural hospitals have entered a government program to turn their facilities to only outpatient or emergency care facilities. Everyone else is triaged out to a major urban area. And just like in the 1960s, when Dr. Ford entered into the process of starting a nurse practitioner program, the reasons that she did that are very much similar. They're needed, advanced nursing roles are needed to offer care to underserved, whether it be in rural or urban settings across the country. And you're in review the nurse's scope of practice, practitioner scope of practice, excuse me. It's nearly identical to a primary care provider scope of practice. The major difference is education. These differences in education and years spent drives a discussion, once again, about whether the APRN is knowledgeable enough to be granted medical membership or to be considered a primary care provider. So the objectives of this presentation, now that we have some background, are to differentiate the APRN scope of practice and the APRN practice authority, to outline the aspects that the APRN scope of practice governs, and to compare APRN collaborative and independent practice options. So what is the APRN scope of practice? Each state has laws regarding the rules and regulations a nurse must comply with to practice in a specific state. There is a movement to consolidate the APRN practice to all 50 states, which would help to lead a more consistent process for practicing or crossing state lines. Currently, the scope of practice is determined by a state regulatory board, which is usually a state board of nursing. There are 9 practice components within the APRN scope of practice, and we will look at those in this next slide. The level of practice authority is one component of the scope of practice and is dependent on each state's regulatory board. And as of October 2023, the number of states that grant full practice authority has risen to 28, with New York and Kansas being the latest additions. The 3 levels, according to the American Association of Nurse Practitioners website, for practice authority is full practice, which allows all NPs to evaluate patients, diagnose, order, and interpret diagnostic tests, initiate and manage treatments, including prescribing medications and controlled substances, under exclusive licensure authority within the state board of nursing. And this is the model that is recommended by the National Academy of Medicine and the National Council of State Boards of Nursing. The reduced practice reduces the ability of nurse practitioners to engage in at least one of the 9 elements of practice. The state law requires in this situation a career-long physician collaborative agreement with another health provider for the nurse practitioner to provide care, or it limits the setting of where a nurse practitioner can practice. Restricted practice requires the nurse practitioner to have career-long supervision, delegation, or team management by another health provider in order for the NP to provide patient care. The state practice and licensure laws restrict the ability of nurse practitioners to engage in at least one element or more of nurse practice. So you can see here how the states are designated, and you're starting to see more green appear within the contiguous United States. So this set of tables provides a picture of what differs between states. I recommend the source listed in the slide to reference the status of each state. For example, in Georgia, nurse practice is restricted. The nurse practitioner is not able to practice autonomously. They must have a career-long affiliation with a physician, delegation, or team management. By contrast, in Idaho, the nurse practitioner has full practice. They may practice autonomously and deliver care in the primary care setting, which allows for assessment, diagnosis, and treatment of the patient independently also do all other practice components, but continue to have some form of restriction on membership as a medical staff person. Autonomy is not the same as independence. In fact, it's more about being experienced enough in practice to know when you need help or you need to consult with others along the way. But to our detriment, nursing has not clearly articulated autonomy as a concept to other providers, legislators, or stakeholders in such a manner that restrictions would be totally removed. The personal and professional attributes guide to the NP's ability to practice within a full practice authority, but the professional attributes rely on health policy, and these come from local, state, and national legislation outlining the role of practice that nurse practitioners provide as a member of a self-governing body of APRNs. Till recognition for nurse practitioners to be seen as a provider occurs, there will continue to be limitations on nurses reaching their fullest capabilities. The only exception to this would fall under the Veterans Administration, where advanced practice nurses act within the scope of their VA employment. If nurse practitioners practice within the VA system, they may, with full practice authority, independently prescribe controlled substances regardless of the state restrictions. But if they practice outside the VA system, they will not necessarily be able to mimic the same practice elements, and they would need to follow their state regulations. So if full practice authority is the culmination of personal and professional achievements and competence proven in practice, education, and certification, then the nurse practitioner autonomy should be defined as the nurse practitioner's use of their experience, clinical judgment, and responsibility to practice without restriction in professional collaboration with other healthcare professionals. Independent or collaborative, that's the question. Dr. Loretta Ford, pictured here, who I mentioned earlier, apparently did not appreciate the term independent practitioner. She believed that all practice requires teamwork and collaboration. And many of you during the discussions have supported Dr. Ford's belief that consulting with others strengthens clinical judgment, provides a safety net to assess various views and concerns over practice issues. This sentiment also is the 6th AACN Essential for Practice, titled Interprofessional Collaboration for Improving Patient and Population Health Outcomes. While you can open your own practice as a nurse practitioner, the exact operating rules vary by the state in which you'll be operating. If you're an NP working in a state that grants full practice authority, you may want to open your own practice without physicians supervising or approving your work. There are many factors to consider before you jump into this practice model, and there's a multitude of articles and videos that can provide you with other experiences of opening their own practices, and that what they just provide a valuable advice on what to do and what to avoid. There are several considerations that are most important, and the one that keeps recurring is making sure that you know the law and that you obtain an attorney to help you get started. You have lots of certifications, credentialing, specific unique numbers to your license, the types of insurance, the startup money, your infrastructure, and making sure that you have mentors and supporters that are going to help you open your business and make it successful are really important. But the number one thing that they all say is you need to know why you want to open this practice. It is so important that you go back to the initial reason or your passion for wanting to do this. And if you don't have that why completely articulated, you're not going to have that fail-safe support structure there that sets the foundation for why you're wanting to put yourself into a situation of complete ownership and responsibility. So I think it's very important that you look to anything that you can find to get advice and make sure that you have those things in place and that you've answered these questions, or you go through a toolkit or whatever that's established through AHRQ or through the Nurse Practitioner Association, that will help you find that information that you need to tick off this checklist and make sure you have your ducks in a row before you get started. The response to paying for collaborative practice agreements has proven to be a mixed bag. For the nurse practitioner that's required to have an MD supervising aspects of care, it can be seen as a detriment and a way for physicians to capitalize on adding this income as a second source of income for them. This slide demonstrates the expenditure variances and helps you to understand what you may need to budget for this agreement depending on where you work, how independent you plan to be in your practice, and if you have ways to evaluate the quality and quantity of the work this physician is providing for your needs. Most of the results of the studies performed on this topic revealed that many times the physician is not readily available, and patient care-related decisions are delayed, or the nurse practitioner is constrained from providing immediate care outside of emergency management, mainly because the physician was not available. There are services that advertise to help nurse practitioners obtain a physician in a short period of time to help with certifications or credentialings, but it is not cheap, and you pay for those services. It may be the reason why some nurse practitioners choose to be a part of a team or a group rather than venture to their own independent practices, so they don't have to pay for this service. It's an option, though, and you should consider it. But if you do consider it, go into it carefully, knowing that you have enough money to budget for this monthly fee, the setup fee, and that the physician is going to be there for you in your time of need. Team-based care fits into the value-based model of care that has replaced the retreatment-based system we've worked with for decades. Team care prevents fragmentation of care through collaborative communication, and it supports these attributes. It improves quality by providing patients with the treatment they need when they need it. It reduces costs by preventing expensive and avoidable hospitalizations, emergency room visits, and complications, especially for patients with complex chronic conditions. It improves the patient experience by providing personalized, comprehensive, coordinated care that patients want. And it improves staff satisfaction systems and structures that help the staff work more efficiently. And it improves provider satisfaction by uncovering unforeseen patient problems, conveys unique needs to the team, allows relief of some of the pressure by using the expertise of team members to handle various aspects of the patient's care. One of the options for delivering team-based care is the medical home. The medical home encompasses some of these same attributes. They're comprehensive care, patient-centered care, coordinated care, accessibility to services, and quality and safety measures. Co-management is also an option for nurse practitioners to consider, especially in states where there are reduced or restricted levels of authority. The process of co-management enables providers to realistically complete recommended care guideline tasks, but variations remain in how co-management is conducted. In states where there is reduced, restricted, or even in some cases full nurse practice authority, the physician remains involved in care oversight based on the individual state laws. But in the truest definition, co-management structures are two or more providers sharing joint responsibility for completing all the required care management tasks for the same primary care patient. They did a survey of physicians and nurse practitioners back in 2019 to discuss co-management of patients in primary care practices. This qualitative study resulted in three themes that you see on this slide here: joint care management, attributes for effective co-management, and implications of nurse practitioner to MD co-management. When working together as a team with one goal in mind, good patient outcomes and quality care provision, it makes sense that regardless of the level of granted practice authority, it is mostly understood that not one provider knows everything. To have relationships in a practice that's co-managed means that competencies dependent on the professional education and clinical experiences are different, and each member of the team can learn and gain the benefits of shared work, and that there's a shared responsibility, shared workload, which in turn can lead to less stress and burnout among providers. Patients are then not seen as one member's patient, the patient shared by all on the team. And in that perspective, the most effective co-management teams provide effective communication through their meticulous documentation and direct consultation when the care is provided and has the potential to be seamless. Of course, limitations do exist relative to whether the location of this team has rural outreach and if the infrastructure of this practice allows for the outreach into the community, or if there are community support resources that will assist in ensuring that the patients that they serve get the care that they need when they need it. So in summary, know the law regarding your APRN scope of practice in your state or states. If you work in more than one state, please be careful to stay within each scope of practice. Where you practice has much to do with your decision how, where, and who you want to work with. Of course, there's advantages and disadvantages to being an independent practitioner, working solo, or working within a group or team environment with someone else in charge of the practice. Know the population you serve. Many patients don't even know that nurse practitioners can provide care on par with their primary care provider. That shows that nursing entities really need to provide better marketing and promotion of what advanced practice nurses can provide to the community in and out of hospital settings. And understand that independence does not mean that you are all alone in your decision making. In fact, it's an essential of our practice to collaborate with others. Opening an independent practice requires knowledge of running a business. And autonomy is much like self-actualization, in that you learn about yourself, you learn to abide by ethics standards, mature use of resources, and gain humility for knowing that you are now responsible for the decisions of patient outcomes, for which some is too daunting, for others it's a goal towards fulfilling a dream. If you don't have business acumen, you need to hitch your wagon to those who do. Find a mentor, listen to experts, network within your professional organization to find grants, loans, and mentors available as part of your membership. And use social media to your advantage to make connections and to learn from others. I want to thank you again for attending this presentation, and my resources are attached to the next 2 slides. Thank you again. Here are my resources.